We are going to have 3 presentations before we go for lunch. So kindly let us just be patient and listen in. Dr. Eda was CC for health. Also previously, so he has bounced back for another 5 years. Let's give him support. And he was also the chair of the CC Health. Our former chair was Professor Muga, who handed over the baton to him. And now he's acting chair. But I know after election in the next, so things may change, we don't know, we pray. But currently he's still the acting until he hand over back the baton. So kindly allow him, let's give him applause as he's actually doing this presentation. We are going to have the 3 presentations and have 1 plenary session before we go for lunch. Very good stories, you will hear it from him. Karibu Waziri.
Your Excellency, the Deputy Governor, Isiolo County, doubling up also as the Health Executive, development partners present, representatives of national government, Ministry of Health, the CEO of National Council of Persons with Disabilities, former colleagues who are facilitators and presenters, current county executive members, the COG Secretariat. Good afternoon. It is my pleasure to take the next few minutes to just take you through a few of the many things the county governments have done in the health sector after the inception of devolution. I stand here today coming from a county that has been neglected before devolution 2013, and a county that actually 2013, the 2010 constitution gave a second independence. So I share that kind of background with very many counties, but I will just slightly highlight on 1 or 2 or 3 things that have changed remarkably for health. I am in the health sector for 27 years, although physically I look young. I'm a medical doctor by profession, largely initially based in Mombasa, but later on taken up by devolution. I'm also one of the few survivors. I think we are 5 of us that survived the last elections to be nominated again, and for that matter again by a new governor. My former governor had served his 2 terms. Next slide. So it is not possible to condense what the county governments have done in the last 10 years. The achievements have been tremendous. So it is not possible to condense everything in 15 minutes. Because from Mombasa to Mandera, Turkana to Taita Taveta, Kitui to Kisumu, Lamu to Laikipia, Busia to Baringo, Kilifi to Kakamega, Nandi to Nairobi. Everything good has been happening in the building blocks. In the building blocks of health, everything good has been happening. So I'll just pick on 1 or 2 or 3 things. And that is the session objective. That is basically just to look at the Constitution of Kenya. In as much as we are health managers, there's a lot of things that is in the Constitution very, very relevant to us. The rights of the Kenyans that we are supposed to be giving them as an obligation, not as, a privilege. The regional and international treaties, health sector policy, and county health sector performance. So number 4 is where I'll put a lot of the efforts, because most of the other issues will also be tackled by other presenters. Next slide. Yeah, 10 years. We are happy people. And the fact that the new county executives and the development partners and the Ministry of Health and the Kenyan government, we are all gearing towards Vision 2030. So after 10 years of reflection, after today, 10 more years, actually it is less than 10 years. In Kenya's Vision 2030 is supposed to be 8 years from now. We're in 2022. We do expect, as county executives, after another 8 years, to be able to say we have picked up health from here to where it is today. Next. That is the new dawn for Kenya, and for some reason, this date, I have taught all my children this date, and the youngest is about 2 years old, and he knows 27th August 2010, because it is that important to us as Kenyans. And there's also something significant about this this date, 27th. 27th of October, so I'm just mentioning the date, is when heads of state reaffirmed Alma-Ata Declaration at Astana conference. Then again, the Abuja Declaration on HIV, AIDS, and TB. This was again on 27th, somewhere April 2001. So maybe there's something good with this number. Next slide. The new constitution and health. So I want all of us, the county executives, as you settle in, get time every day to at least look something in the constitution relevant to health. Because it is our job to be able to make sure that mandates in health that is in the constitution is fulfilled. So as far as the constitution is concerned, we all know chapter 1 is about the sovereignty of the Kenyan people and supremacy of the constitution. Chapter 2 about the republic. Chapter 3 about the citizenship. And chapter 4 is now where the Bill of Rights are. And under that bill you can see, under Article 43(1)(a), that every person has the right to the highest attainable standard of health, regardless of where this Kenyan is, whether he's in Mandera, Turkana, Nairobi, every other place. And the word is underlined, the highest attainable standard of health. So this is a Bill of Rights, it's not a negotiable thing. What are we going to change in as far as our health systems currently is concerned, so that then every Kenyan in every county has got the right to the highest attainable standard of health. Next. In this next slide, the Constitution of Kenya and transfer of health services. Again, the fourth schedule of the Constitution vests county governments with the role of providing basic health services, while the national government is vested with national policies, standard setting, tertiary institutions of health running these institutions. So you realize that there are functions that are belonging to the county by virtue of the Constitution, and others belonging to the national government. In between, there are also cross-cutting issues as well as emerging issues that now we also need to look at it. Because there are some areas in which things are not very clear, and there are overlapping roles that may bring about conflict. And therefore, health services was devolved through that legal notice number that you're seeing. Again, in the fourth schedule, something again about this figure 4. There is the fourth schedule, there is the big 4 agenda, and I'm sure there are very many other 4s relevant to health. Next slide. Those are some of the functions of the county governments devolved in the health sector by the Constitution. Promotion of primary health care services, ambulance services, cemeteries and funerals, solid waste disposal, and these other ones. There are, of course, areas that we are, as county governments, we are in discussion with the national government on the best way of going forward with it. And those are some of the probably issues. Some of them are legal issues that, next presenters on those topics are going to talk about it. Now, the county governments are expected to establish structures and systems for delivery of health functions. This has been done largely. We are going to see it in the coming few slides. There are, of course, challenges, and there are legal challenges. Some are acts of parliament that were previously passed, and there are bottleneck. There are cases between the county government, issues between the county government and the Ministry of Health, national government, that was not very clear. There was a lot of discussions and, coming to a mutual agreement on it, and some issues have gone to court. The issue of the Tissue and Transplant Authority, the issue of national syndemic disease control, and other things. So we have got areas that are still gray, and that I leave it for the, the legal people who will come after me. Next. Now, Kenya is a signatory party to very many international protocols as a responsible country, a country that very many in the world look at in terms of leadership, in terms of peace and stability, and in terms of so many other good things. Very many African countries and even Asian countries have borrowed policies that were developed by Kenya, to be able to make it a working document for their people, and they have come, they have progressed very far. One time, in I think one of the health conferences, Her Excellency Charity Ngilu, former Governor Kitui, in a conference in which the President was also seated in Mombasa, that is Serena, she talked about one time as a cabinet secretary, she went to Malaysia to go and have, a look at how Malaysia has developed their national health insurance system, the social protection system. And she said when I came, she was to be received by her counterpart, the Malaysian Minister for Health. So when she came that morning, she was checked into the hotel, and when she came to the cabinet secretary's office, two things that she said clicked with all of us. Number one, she was told the minister is not in, so you're going to be handled by the assistant minister. And when she asked where is the minister, because he knew I was coming, she was told there was a maternal mortality in some remote province in Malaysia. And as a line of responsibility, the Minister for Health had gone to see how on earth did a mother die while giving birth. That is the level of responsibility that countries attach, that we need to borrow as counties and as a country. That is, from the position of responsibility as a CEC, if you hear there's a maternal mortality somewhere, you take it upon yourself without delegating. How did this happen? Preside over it, because that is how changes are brought about. The second thing, the assistant minister told her, here is a document. I am sorry, I may not be able to take you through. He will come himself. But here is a document that we used to transform Malaysian health sector social protection system. Only for her to open and find it is a Kenyan policy developed long ago, just immediately after independence, yes, that this is what she was given to go and transform Kenya. A document that, developed in Kenya, used by other countries. Same thing for, eye care services in Tanzania. Tanzania is one of the most advanced eye care services in East Africa. And what did they use? They used policies developed by the Ministry of Health, Kenya. And very many other countries are doing that. So we must not only develop policies and keep them, on shelf, but we actualize those policies to be able to make sure Kenyans in the next 10 years will be proud of this generation that is currently present. Next. Again, the health sector policy direction, overall health sector policy direction is guided by Vision 2030. And as you all know, health is one of the social pillars anchored in that vision. The vision is for Kenya to be a newly industrializing country with a population that is attaining the highest standards of health in a secure and safe environment. So again, you can see health is a very serious pillar of Vision 2030. Next. That is a slide just on the same policy direction. As you are seeing, on the policy orientations, we have got the building blocks on one side, which is the health financing, health leadership, products and technologies. And this is supposed to be geared towards policy objectives to eliminate communicable diseases, halt and reverse the burden of rising challenges of non-communicable diseases, to reduce the burden of violence and injuries, provide essential health care. And that we are talking about, you are going towards universal health coverage, or universal health care. Minimize exposure to health risk. And finally, the policy is to attain the highest possible standards of health in a responsive manner as part of Vision 2030. And all of us here collectively, together with our partners, are the ones to make sure that by 2030 then we have achieved this vision by building slowly on what is already there. Next slide. So again, that is just another slide to point home what the whole process is and where we are going. That is towards universal health coverage. Next slide. So various initiatives have been put in place to enhance access to quality health services, including provision of free primary health care programs through conditional grants, free maternity service at public health facilities. Particularly all the level 3s, level 1, 2, 3 are free in terms of services being accessed. At level 4s, there's a lot of services that's again free, particularly with respect to maternal and child health. So enhancing equipment capacity, provision of insurance subsidies for the poor. Again, this is through NHIF. And there are some counties which are better than others, and therefore we are here to learn from each other and benchmark with the best. We have Kisumu that has piloted the Marawa scheme, in which very many vulnerable households have been captured. There's the national government initiative where 1 million indigents across the 47 counties were to be enrolled. There's Makueni that is also having its own, unique kind of things. So as county executives, we will be benchmarking with each other to see what is the best method, because ultimately we will all need to go towards universal health coverage and primary health care system that has been, identified as the bedrock. And I'm happy that Dr. Meshak, you are here as AMREF. I know AMREF and other partners who are involved in this initiative of making sure that we invest more in primary healthcare system for us to be able then to cut down on patients flowing into level 4s and level 5s. So we will come to you so that we look at what is the best practice for all the 47 of us then to be able to say we are sharing in this vision and this is the direction to go, so that we are on equal footing terms as we go towards the vision. Next slide. Good. This is how has health performed under devolved governance. Now, this is the area that I want to concentrate in, maybe for a few more minutes. And I will want to refer to a few counties, starting from myself. In terms of access to infrastructure, the county governments have immensely, either they have doubled or tripled the number of facilities available, because this is the basic thing for somebody to have access. If you have a facility, a health facility, then your people have access. In Mandera County, the distance between two facilities before 2013 was 50 kilometers. That is the range. We had 34 health facilities when we came in. The county referral hospital, the current county referral was a health center. And so you can talk about now the rest of the current level 4s. They were actually dispensaries. So we had to now fight back and invest. And today we have got 112 health facilities. We have slightly cut down the distance the public has to go to, to meet a health facility for healthcare services. And that is true for all other counties. Dilapidated infrastructure that has been, rehabilitated, equipments that were initially dead or, unused, being used. So this was a very, very heavy investment on the side of the county governments. Next slide. Next slide, please. Good. This is just one example of some of the things the county governments have done. This is Makueni Child and Mother Hospital. It is, I'm told, 110-bed capacity hospital. Something that was initially not there in Makueni. Next. From a dispensary, this is the accident and emergency unit of Mandera County Referral Hospital. And so it's just part of the infrastructure investments that you are seeing. And very many counties have done something equivalent or bigger. We have got Kisumu that has, uplifted, facelifted Jaramogi Oginga Odinga Hospital, and very many other, counties. I have gone to Nakuru last year to go and look at their complex outpatient that is coming up. And I must say I'm immensely proud. I'll talk about Nakuru at some point, when I'll be talking about something to do with financial commitments of county government. Next. Now, the county governments have also increased, budgetary allocation to Ministry of Health of the county governments. And as you can see that figure, the way it runs, in 2013, 2014, when devolution came in, you can see the county contribution was 42 billion and the national government contribution was 36 billion. This was a dip from previous, because previously, as you can see, we were at 8%. Now we are at 5.5%. Now that dip will be explained later in the plenary. Next. The human resource, again, this is something that is each one of us knows in every county. When I went to Mandera County, we had only one consultant surgeon. Today we have got 12 consultants. We have got 17 more on study leave. Kisii County is a poster county in terms of the number of personnel that have gone for studies. We have now got more specialists and more mid-level specialized cadres than before. So again, these are some of the achievements of the county government. Next slide. The health commodities and technologies. Now, after the human resource, the recurrent expenditures of Ministry of Health across the counties, after HRH, the next thing that takes a lot of budget is the health commodities. That is the supplies. And most counties have stable and predictable supply systems. The range of products have been expanded. Of course, most of us are working closely with KEMSA, except where they, apart from areas in which they may not be having drugs when we give, the supply orders. But we have also eliminated largely the push system where things are pushed. You have not ordered it and you find things that you have not ordered, in the county. So this has been eliminated. And some of, the achievements of the county governments. Next. Increased range of services. This one I think we all know. Everybody in his county. One thing that was not available before that is available currently. Be that dialysis services, ICU services, diagnostic services that were hitherto not there. And I've just given few case examples. Mombasa with the state of cardiac cath labs, ICU and dialysis centers in most counties, Nakuru, Mombasa and Garissa with that, and oxygen availability across. So these are some of the few things, because like I said, I cannot condense everything the counties have done in a 15-minute presentation. Next. This is oncology unit. I accompanied Her Excellency, the First Lady of Kisumu County. We had gone to benchmark between Kisumu and Mandera to go and benchmark with KIU Teaching and Referral Hospital. That's a model center for cancer in the country, and maybe at one point we will make arrangements to go and visit so that we see what we can copy. Machakos has got a good comprehensive cancer care unit, and so this is some of the vision of the counties. I know regional cancer centers in Garissa, I've talked about it, Nakuru and Mombasa, plus other counties. Next. This is, this person is an Ethiopian. The county referral acts as a regional, center, and we treat patients from across the borders. This is an open chest surgery in 2019, something that is unheard of before devolution. Next. The next slide, as you can see, is county legislations. Again, I will not go into this, but I will only talk about the FIF bill. And what I will say is just echoing exactly what His Excellency the Chairman, Mudoki Njuko, has just said, that our CECs, all of us who have not passed this bill, some counties, I know it is not because of the CEC, but because of the county assembly. We need to make this as the first agenda after today, that before June, the end of, the current financial year, before June next year, every county, all the 47 counties must have, passed the FIF bill. And this is what we are going to make sure we are going to collaborate on this, share the good experiences, how the bill looks like, what are the regulations, so on and so forth. Next. Coordinated response to pandemics and epidemics. You have seen the role of county governments. COVID was, it was good and bad in its own ways. Good in that it started showing us our nakedness in the health sector. You want an ICU, it is not available. It is your mother who is sick. Or maybe it is, a very senior person in the county government who is sick. So suddenly we started having resources being mobilized for the health sector. And this is what we need to do, because Kenya now is investing about 11% of the GDP to health. That is way below, what was agreed in Abuja, that is 15%. We need to maybe move even towards 2030, so that then we can be able to have everything that is required in health for us to be a stable, country that is living to the spirit of the Constitution. That is self-explanatory. The county leaderships, ourselves plus our teams, are expected to establish functional monitoring systems. Because at the end of the day, whatever it is that we are doing, data must be the baseline that informs the decisions that we do. And anything that is not good in the data is what needs to be created, and that is where resources need to be put, particularly in the primary health care system. Next. I want to end with this last slide. It sums up everything that I have said. And this is His Excellency the President William Samoei Ruto. At that time, he was the Deputy President. This is on 8th of February 2019. The best manifestation of devolution lies in healthcare. For the first time, a cesarean section birth was performed in Mandera, and that was in Takava Sub-County Referral Hospital. The county referral hospital was the only hospital with theater in 2013 for a population of 1.2 million and a county that is as vast as 26,000 square kilometers. So you are to travel 2 days just for a cesarean section of fetal distress. Open heart surgery in Mombasa and brain surgery in Embu. And before devolution, these services were only possible in Nairobi at a great expense. So, ladies and gentlemen, I just wanted to exit with a few things. Every generation that comes bequeaths another generation something. For this generation, that is us, the current crop of county executive, let it be said in history by the coming generations that we took Kenya to excellent position in health service delivery when we reach Vision 2030. We need to cut down maternal mortality from what it is, and it is possible, very, very possible. It's unacceptable, even if we cannot say 0, but we can go below 50. Is that not possible as we go towards 2030? You can see what Malaysia has done. The minister goes to look at how did a mother die. That's the level of responsibility and investment in their population. The primary health care. This is again something that we must achieve. 98% or more or 100% of immunization coverage. These are simple, attainable objectives that I want to exit with. And to just say 3 things that His Excellency, the Chair had just said. FIF bill, remember this is a watershed moment. Between now and June, we are available, we will work with the COG, we will look at these bills that were developed by other counties, whether it requires enriching or whether we need to go that. The caucus, and this is again emphasized by the Chair, we must work for the counties. We must never work at cross purpose. We work for the counties, but in partnership with the development partners and the national government's Ministry of Health, where the interests of the county governments in health sector is not in congruence with any other agenda, then we go with the agenda of the county government's health sector. That is the way we expect out of the caucus. And finally, ladies and gentlemen, the county directors of health, I'm just echoing the thing that His Excellency has said. As we go, we have got a lot of things to learn from each other, both in terms of supervision, line duties, what tasks need to be done by who, from the office of the CC to the chief of SAS to the directors. What is their role? What performance do you need to put into their, into their appraisal system? So thank you very much.
Thank you very much, Waziri Eda. Another round of applause. So as I said earlier, we are going to have one plenary session before lunch. So at this juncture, allow me to invite Dr. Mutaha Kangu. Dr. Mutaha Kangu is a constitutional lawyer, very rich in knowledge in terms of law and legal matters. He works at the secretariat at COG. So I think most of you know him. So at any one time, you are free to actually consult him. So Dr. Mutaha, I'll give you
the all protocols observed. I don't want to name everybody, but to start by saying that I'm very, very happy to make a presentation to this very distinguished gathering. Now, picking from what was said this morning, particularly by the chair of the kinds of governors, the chair of the Committee on Health, you are people who are going to play a critical role in policy making, in making policy decisions that will take health forward. You will have to advise the governor. Sometimes you will have to persuade the MCAs to pass certain legislations. And in this presentation, therefore, I will not go into details. Other following presentations will go into the details of policies. But I want to do some introduction to show you some of the things you will need to do. Where is Walter? This thing is not working for me. Okay, fine. So the presentation I'm going to make will have to try and help you to see what is the meaning of a policy. Number two, you need to get a little information about the process of public policy making, because you will be at the center of it. Number three, you will also have to understand a bit about the constitutional allocation of the function on policy. Is it just a national government function only, or do the county governments have some role in policy making? Number four, you will need to understand the linkage between county government policies and national government policies and legislations. Is something happening? I'm not seeing what is supposed to be here. So I'll use, so the linkage between the policies at the national level and the legislations. And a very important thing, number five, because we'll be seeing that there are very many policies that have been developed at the national level, but which have not been implemented. Part of the reason being that they have not been translated into legislation. And so we would want to understand, how do you determine whether a policy requires to be translated into legislation? And finally, we will look at issues for the implementation of policies. What are some of the challenges you need to look at? And the objective is actually to get you understand this process, appreciate, because on a day-to-day basis, these are the issues you will be dealing with. Now, if we come to the meaning, we need to observe that a policy is defined as a purposeful statement of intent, written or spoken, which is aimed at guiding actions and decisions to achieve rational outcomes or solving specific problems. And I wanted to emphasize written or spoken, because sometimes a lot of you will think about policy from the perspective of formal documents. But a lot of policies are decisions that sometimes are not even put in formal documents that are regarded as policies. You will have sometimes to issue circulars and things like that. They are all policy decisions, and they are important. And these policies set out the goals and activities planned to achieve a certain purpose. And they begin as ideas for government, in the case of the government, policy making is then the process by which the governments translate their vision into programs. And the public policy, therefore, must be made by a public authority on behalf of the public. And you know, now you are senior, important public officers at the county level. You're making these policies for the public. It must be a product of demand. Don't just wake up with the ideas which you have not researched and determined whether they are required and then you say you are throwing around a policy. It must be purposive and goal-oriented. What is the goal that you want to achieve? And it must provide guidelines for action, and finally, presuppose a theory of social change. Where do you want to take your county to? From where to where? You need to understand. You need to undertake research. And therefore, you need to know that policy differs from law, regulations, and rules in the sense that while the law can compel or prohibit certain action or actions, certain behavior or actions, policy merely guides actions toward achieving the desired outcome. Moreover, while a legal action can be founded upon law, policy cannot be a foundation of a legal action. And the reason I'm emphasizing this, you need to know that sometimes the reason we are unable to implement our policies is because they may require to be translated into law, and because you have not translated them into law, you cannot take anybody to court on the basis of the policy. But if you had translated it into law, you can go to court and say, this person has infringed this particular law. And therefore, looked at from this broad perspective, what constitutes policy may be much more than what ordinarily is regarded as a policy. And most strategies, statements, and circulars may rightly be regarded as policies. So you are in a position that at the end of the day will be making very many policy decisions. Now, looking at the process, you will note that public policy making has a cycle which entails the following important activities. Number one, identification of the problem, giving rise to the need for a policy. We have already said it must be something that you require, there must be a need for that. And you must identify that problem, research it, understand it. The setting of the agenda, you must set the agenda through research. You must design the policy, and then you must legitimize the policy through adoption by an authorized body. And that's why I said you will need to learn how to talk to MCAs and persuade them, particularly those in the health committee of the county assembly. You need to persuade them, because it will not be enough for you to make your policy, to draft it. You will need to translate it into law, and at that point, you need to persuade the MCAs to pass the proposed bills you bring to them. And then, of course, you must have implementation of the policy and a bit of monitoring and evaluation of the implementation process, so that you know whether it is working or not, where you are making mistakes, and you move on. Now, that process has a number of stages, and you need to look at them. You begin with the initiation. We have already talked about identifying the problem. You research. You negotiate with the stakeholders, players. You have many partners here. And you know our constitution emphasizes public participation. You will need to understand that if you just develop your policy and go ahead, someone will go to court. Umtata is now in the Senate, but I'm sure he will continue suing. Someone will go to court and say there was no public participation. So you need to understand all these things and stages. And then, of course, I talked about authorization, adoption by the authorized body. You then move to a parliamentary or county assembly approval. You have to take it to the county assembly for approval. And then, of course, there will be cabinet or county executive committee approval. You do it in health, but it has to come to the entire county committee as a cabinet to approve it. Then, of course, there is the finalization of the policy. You have listened to people, you have negotiated with them, you have taken their views, you now revise your draft so that you have a proper draft. And then, of course, after it has been passed by the county assembly, it needs to be ascended to by the president at the national level or by the county governor at the county level. So you bring it to him, and then, of course, it has to be published. And beyond that, now you come to the question of, do we need to translate it into legislation or not? You have to make decisions. And so my next slide, and I don't want to go into details on this, you know that the fourth schedule assigns the policy-making function in health to the national government. A lot of people interpret that to mean it is an exclusive function of the national government. But from what I have already so far said, you realize that even county governments have a role in policy making. And if you look at Article 185, which empowers the county government to make laws, and you read that together with Article 10, which talks about rule of law, you will then realize that under rule of law, if you have powers to make policy, then you have powers to translate that policy into legislation. Number two, if you have powers to make law, then you must found your laws on policy. They must be preceded by policy. So if county governments have the function of making laws in health, county laws in health, they do also have a responsibility to make some county policy on health before they translate it into legislation. And we need to bear in mind that while the policies and laws that are made by national government apply to the whole country and in all the 47 counties, county policies and laws are restricted to their respective counties. And that, of course, raises quite a number of issues that we need to understand. That for the delivery of health services in the counties by the county governments to be successful, you need a good policy and legislative environment, both at the national level and at the county level, because your services are guided first by national policies and legislations, and second by county policies and legislations. Now, some of the challenges we have in this linkage between the county and the national policies are that, one, we need to sometimes ask the question, what is the extent of national government policies and legislation? Should they cover the whole field and leave no room to be filled with the diverse county details? And this is a question for national government. Dr. CTNA is here. We need to start asking ourselves, if national government is to make policy for the whole country, and our constitution, one of the objects of devolution is to provide unity in diversity. Is it in order that national government in its policies and legislations should go to the minute details and leave no room to enable counties to be diverse when they are coming up with the details of implementation? Or should there be a cutoff point where they stop, so that national government is providing broad policy, and then you leave county governments to generate detailed policies that may differ from one county to another, but all of them achieve the national objective? These are issues, these are conversations we need to have with the national government on a serious note to get where is the cutoff point, so that we do not give details that are uniform and therefore take away the benefit of diversity, unity in diversity. Then, of course, the need for involvement of county governments in the national government policy and legislation making. Of course, if we look at the Article 189, that establishes the obligations of cooperative devolved government, we have kept insisting that the easier way for the country would be for national government, when they are making policies and legislations, to involve county governments. Because sometimes the county governments are the ones who know the difficulties of implementation on the ground, and they can be able to tell you at the stage of making the policy what will work and what will not work. So that cooperation is extremely important in policy making. And then, of course, the need for dissemination of national government policies to the county governments. Today, we do have very many policies, and you will see in the next presentations, very many policies that have been made at the national level, many of which even the county governments are not aware of. What are we doing to ensure that we disseminate these policies? Because we are making them for use by the county government. It's no use to make them and keep them on the shelves at the national level, and the users do not know about them. And then, of course, we do have many national government policies that have not been translated into legislation, and this is causing problems in terms of implementation by the county governments, and something needs to be done to encourage this. And we are asking the question, can county governments translate them into their own county legislations? And our answer is yes. If national government makes policies and it's not translating them into legislation, county governments can and should study those policies, pick out what they think is important, draft bills, and have them passed in their county assemblies to have them implemented. And I have already said, sometimes it is difficult to implement if you have not translated the policy into legislation. Now, how then do you determine whether a policy requires legislation or not? And there are quite a number of things that you need to consider to determine whether a policy requires a legislation to implement it. Number one, the legal consequences of not translating the policy into legislation, such as the limited options for enforcement to the policy through the judicial process. I've already said, you cannot go to court founding a case on a policy, but you can found your case on legislation. So when you don't translate the policy into legislation, you limit your options of enforcing that policy. Number two, constitutional requirements such as the need for law in limitation of rights under Article 24 of the Constitution. If a policy intends to limit a right, which is guaranteed in the Bill of Rights under the Constitution, you need to look at Article 24, and it says a right can only be limited by a law. So if you intend to limit citizens' rights through a policy, if you don't translate that policy into legislation, you will be told you can't limit my right without using a law. So that is a consideration you need to look at. This policy, is it envisaging that we shall limit rights of some citizens or not? Number three, the need for criminal sanctions where a policy contemplates enforcement through criminal sanctions. If you have a policy which envisages that you will impose some criminal sanctions and penalties, you will be creating criminal offenses. Our own legal system says that you cannot create a criminal offense other than through law. You cannot punish someone for something that is not prescribed by law. And so if a policy is suggesting that there will be need to impose some penalties, some criminal sanctions, you then must translate that policy into legislation. The need to charge fees or impose other penalties where a policy envisages charging of fees or imposition of penalties. If you want to tax people, if the policy is suggesting that you will tax people or you will impose some charges and fees to be paid, if you look at Article 209 of the Constitution, you will see that you cannot impose a tax otherwise than through law. And so you must look at that policy and see those aspects that require imposition of levies and charges and translate them into legislation. Now, the need for establishment of new structures and institutions to implement the policy. If the policy is envisaging that you will establish some new structures which will require funding, you will need to establish those structures through law. Don't just wake up and establish offices. You know the Constitution and the County Government Act says there is the County Public Service Board which has the responsibility to recommend the establishment of offices in the county government, and the county assembly must pass that, and so on. So if you intend to establish structures with the offices, you need to pass law to give you the foundation for doing that. The need for allocation of financial resources to implement the policy. You want to allocate money to the policy, you have no law, the control of budget will come and tell you this budget proposal is unlawful. It is not supported by law. And so you must pass a law if you are going to expend a lot of money on implementing the policy. Finally, the existence of strict timelines and emergency situations requiring urgent implementation of policy. This one sometimes gives you a basis for saying, this is so urgent, COVID has come, we can't wait until we pass law before we can start implementing these policy decisions. So in such a circumstances, you can have exceptions. Thank you very much.
Let's give him a better applause. Anaitwa Professor Mutaha Kango. He can even do this presentation often. Like, it's just, even if he will be walking up, he will just give you the presentation. So he doesn't need even to refer. So thank you very much, Professor Mutaha Kangu. As I said earlier on, he's among the team of experts, the 4 that were actually recruited, supported by USAID, but seconded to COG to support the secretariats. So thank you very much for that. At this juncture, I want to also invite Dr. Sitinei from the Ministry of Health to also take us through the next session. Dr. Sitinei is in the Directorate of Health Policy Research, Monitoring and Evaluation. I know his presentation is also very heavy, but I told him I want us to interact. He just give us overview, then we have a panel session where you can be able to interact. Let us go practical. Sindio? Let us go practical so that you engage them, and even when after lunch, after this plenary, you engage them. So he's here with us the whole day. Kindly find time and sit with him. He's also very rich with knowledge. Sindio?
I don't know. So, Your Excellencies, who are seated here, the donor community, partners implementing CECs, all protocols observed. I think it's easier to say that way. Mine is going to be fairly quick. I was asked to talk about policies and legislation, but then when I reached out to the team, I realized that it was sent to me by mistake. But I also decided that I'll still go ahead because I'm not a lawyer of any kind, and when Professor has talked, I believe he has talked about everything. But I also settled quickly and agreed with Mebo that let me talk about data. So let us talk about data in that manner. First, I would like just to say that our directorate was established in 2019. What's happening? Oh, yeah. As one of the restructuring that has been taking place within the Ministry of Health to implement the Health Act 2017. Prior to this, we had different types of structures within the ministry. And some of those structures were created by people who are seated in this hall, my seniors, including Professor Muga, who taught me also at some stage. So it coordinates, I think there's a problem with the screens here. I can't see. The screens at the front. So it coordinates health policy formulation to guide the health sector to achieve prioritized government health goals, such as the health policy and the UHC policy. And it also provides guidance on matters of health research. And this part becomes important because sometimes people do research in the field without following the right protocol, and sometimes that creates a problem. And then, of course, we do monitoring and evaluation, which is heavily the part that deals with data. So I'll jump that one. I'll also jump that. But I would like just to mention something about data, the type of data that we deal with. In the routine, we do quite a lot of routine data collection, and I think a few of us are fully aware about the digital health, the District Health Information Service 2, which is basically the database that is commonly used by the ministries for planning and also by the counties. So we track the health policy using data. We track the sector plan using the data. The county investment development plans, we also use that to track, we use the data to track. We do annual sector performance review. There is a process which is ongoing and it's almost being completed now for the 2020-2021, which will be shared with you widely. Policy on health research agenda, universal health coverage, DHS and other surveys, M&E for all conditions. Those are the things we do routinely. And then we also do health facility assessments. And we basically run 3 types of databases, the THIS2, the Kenya Master Facility List, and I'll come back to this. And we are now moving towards the new area that I think is important, and I'll focus more on time on those ones. You know that the government is also trying to digitize the health information systems that we are using in this country, moving away from the traditional paper-based systems towards the systems that are going to be digitized and to make our life much easier, to plan appropriately and get the data that we need, and also to be able to monitor the performance of our systems. This slide to me is important because this is exactly what has happened in the field. That in an attempt to digitize the health information systems and the facilities, we've come up with systems which are either disease-specific, M&E systems, or project-specific. And the consequences has led to, of course, to multiple and disparate systems with limited ability to exchange information. And some counties have even found themselves in a situation where they have been locked in by vendors. And then there is, of course, loss of vital data and misuse of health data. The misuse piece is now being addressed by the Data Protection Act. There is a problem with this screen. However, the health information systems should basically address all these issues which have been identified by the World Health Organization. Starting from the information that you require, the availability of the services, quality of the services, all the way to accountability. More often than not, the health information systems that you will find in the counties either focus on one or none or two at most. And therefore, it's its inability to give coherent and concrete information that can be used to make sure that you are able to make informed decisions. So, in addition to that, there are also emerging issues on health data, particularly because as the clients move across in the health facilities, seeking services at the different service delivery points, they are generating data, which is used for planning and to make informed decisions. And there is also increased demand for many players in this space. There are so many people who are interested in data. And this brings me to the question of, to the old adage that I think a few of us may have heard, that in God we trust, all others bring data. I think we've heard that. So everybody seems to be interested in big data at this particular time. And of course, there is the changing health data environment, particularly because of the devolution which has been talked about in the context of digital health innovations that are fast changing, telemedicine, including the devices that we wear, health data in the context of research, how should research be handled, how should the data be handled for the national good and also for the individual good, and how do you deal with data that is not directly linked to individuals, such as health equipment, and yet the law is very clear. One thing that we may not know is that most of the health equipment that we have in our facilities do have what is called exhaust data, which flies back to the manufacturer of the equipment without your consent. And that is creating issues. And of course, health data in the context of Data Protection Act 2019. So there are several things that the government has tried to do to try to make data much more fruitful and useful for the sector and for everybody who deals with the data. The first thing that has been done, and I'm glad that this has been talked about by my senior, is the identification of the development of the policy on unique patient identification. That policy is now complete from the ministry's perspective. The next thing to do is to make sure that we legislate that so that it can become something that is being used widely. There is a misconception that the unique patient identification is meant for HIV patients. That is not true. It is for all patients who seek care in health facilities. And this becomes important because there's a problem here. Because of the fact that without uniquely identifying an individual, then you lose their prior data. And you cannot get a comprehensive picture of that individual when this person moves to the next step for care. We have also developed the health data governance framework. This becomes important again. It makes me turn this way. Yeah, so the health data governance means that we need to agree on how this data can be shared within the health sector, and more importantly, how can people be able to use this data to make informed decisions in the context of the Data Protection Act 2019. And of course, we have also come up with the standards for and guidelines for the National Health Data Center, which has been developed. I'll come back to this slightly later. And there is something else that has come into place, what we call the National Health Data Dictionary. This is a terminology service tool that will be used to make terminologies in health services in the country to be uniform. And this is one step towards making sure that when patients move from one facility to another facility, the same terminologies that are used across board, so that people in Kisumu do not use terms that may not be the same as the people in Kakamega or other places. They should all be the same. I think Kenya, apart from 2 other countries in Africa, have moved into this space. More often than not, different systems use different terminologies, and that creates problems when the country wants to move towards a unified system. And of course, there is the digital health platform blueprint, which is coming up. This is just to tell us which direction is the country taking in relation to collection of health data in totality, and not in a facility, and not by using one type of system. But as I think it was Brian who talked about this earlier, in an integrated manner that we focus on all the patients, or the patient in totality. The rest are still there. Those are the shared resources. And this is in an attempt towards making sure that we implement the Data Protection Act, which has classified the health data as sensitive data. And our Kenya government has moved ahead to make health data to be considered as security data. So it is a major issue when it comes to dealing with that. That is the vision. It is anchored on the law that we are lifting this from the Health Act 2017, Section 105, development of a comprehensive integrated health information system. In other words, it is comprehensive patient level data through the shared file. When I say shared file, and you can go to any facility and still be able to access your file, and it provides for the service statistics. When we say it's integrated, we mean it is the system brings together all important databases in the country, including KEMSA, NHIF, IPRS. So far, this system is already integrated with NHIF and the IPRS. Sometimes people wait for Huduma number, but meanwhile, we are using the IPRS. And then the regulatory bodies, because of the highest attainable standard of health, it means you must improve the quality of services. And if you are going to use quacks, then they will not be able to provide that service, and therefore the system is linked to the regulatory bodies to shut down those who have not met the requirements. The system is also integrated with M-Pesa as I speak right now. It will go on with the rest, and it will provide the platform for telemedicine. And this is important because as we move ahead to provide access to services closer to the place where the person is, we must adopt telemedicine. Already the guidelines for telemedicine are being finalized, and it will assist us towards meeting the requirements of the law in making sure that the Article 43(1)(a), the highest attainable standard of health. The advantages are immense, good people. And these are the advantages that we miss sometimes. The fact that we have not gotten an integrated health information system means that we miss out on all this. But I would like to point out some of the most critical ones that I think are important for us. First is the customer and client interaction, because it provides that the customer, seated or wherever they are, they can be able to interact with the system. So if you are at home and you have your smartphone, you can be able to monitor your blood pressure, upload your blood pressure details into the system. You can see where is the nearest service, wherever you are. You can book your appointments online. That is the direction you want to go. And that is in the same principles that the e-citizen portal is doing. So if you go to your web browser now and type portal.health.go.ke, portal.health.go.ke, you will find two services there. One is for chanjo, which I think all of us must have gotten the vaccines, and therefore you can pull your certificate from there. The other one is for blood information system. And for the blood information system, you can now be able to upload your details and be a donor at the comfort of your house, and you can go to the facility of your choice to go and donate blood. That is one of the critical things that I would like to mention. The other one is, of course, to do with analytics. And in analytics, one of the problems that we face is that we don't have enough data to plan adequately. My previous speakers have talked about commodities. We will never get to know how much commodities you need in a facility if you don't have a comprehensive system. And this system accounts for the commodities right from KEMSA all the way to the mouth of the patient. So the system will be able to tell you how much was consumed in a day and by who. And you can be able to aggregate that to the week, to the month, to the year. So we can be able to do subnational planning at the facility level and also at the national level. And this will assist the country to do national planning. So that becomes very important when it comes to commodities. In addition to that, you can visualize which commodities are available where in the pipeline. Finally, it will also assist you to deal with the expiries, because we still have a lot of wastage in terms of expiries. This system will alert you that you have in stock something that is going to expire soon and you must do something. And it will also alert you when your stock control levels fall below 2 months, that you are running low on a particular commodity, and therefore you need to order for it. The rest are the details, and more importantly, this is a government project. And it is not just the Ministry of Health that is dealing with this. I want to single out Ministry of Interior, which is dealing with the security and confidentiality and the privacy of the data that is going to be transmitted. So they are looking at all those aspects. The Ministry of ICT is rolling out the fiber, and you will see slightly later that we have now more than 10,000 kilometers of fiber, still ongoing. More than 100 facilities are being connected. I think as we move to the new year, we'll get another 100. And I'm talking about the big hospitals, not the health facilities which are below level 4. These are big hospitals. And they are also doing local area networks. And then the Ministry of Energy is also dealing with power and wiring of the systems. That will be the national architecture. This is where everybody will plug in. Remember, I used the word integrated and comprehensive. So everybody will be wired in one way or another, with the center being the modules. From level 1 to level 6, through the interoperability layer, you can be able to be linked either to state or non-state databases. And with this comprehensive type of system, we should be able now, for the first time, to plan for whatever we need, including mapping of diseases, where they occur at any single time. So far, the project has moved ahead. These are the ones which have been completed, starting from Chanjo, which all of us must have used, the blood information system, which is being rolled out, and I think I had a facility where they're having problems with blood somewhere in Northeastern. This will cure it because you'll be able to see, to visualize where blood is at any single time, and you can also be able to order online. The Jitenge system, which tracks COVID, this one is going to be enhanced to be as surveillance tool. The Afya KE, in terms of inpatient, outpatient modules, all these are available. Telemedicine platform, Isiolo County and Kenyatta Hospital are already running telemedicine as on the pilot stage, but this needs to be launched and then expanded. Then we have the National Health Data Dictionary, which has already been completed, and there are some services which are already being consumed by several other applications. ECHIS, this is Electronic Community Health Information System. This is what is happening at the lowest level. Already this has been finalized in terms of piloting in Isiolo, Kisumu, and now it's being rolled out in Migori. And then, of course, the issue of the infrastructure, and the numbers are increasing every other minute. That is the blood information system, which tracks blood from the first vein to the second vein, including everything else. That is Chanjo, that we all know about, that we have used. And if you have not used this, just go to portal.health.go.ke. You will see that. This is the telemedicine project that I talked about. That is the fiber. And in this fiber, we are also going to have this to be the platform through which we are going to roll out telemedicine in the country. What I would like to say is that when the fiber is connected to your facility, you basically have free internet services in that facility. That is what it means. It also means you can be able to transact much more and to be linked to the other health facilities in such a manner that the patient can move from that facility to the next facility without carrying anything except unique identification. And because of the use of the video conference, which we don't have within the ministry, we are now using the Konza City to provide the video conference platform. And these are the areas that we call upon the counties and the partners to support, starting from the health, the human resources. Of course, change management is a big thing. And sometimes when the government starts to roll this program, we find some resistance because some people in the field think that the government want to kick out everybody in the space of digitization. That is not true. What we are saying is we want to integrate with whichever system that you have in your facility so that you can be able to get the holistic picture of what is happening. The question of infrastructure, particularly on the local area networks, is a big issue. Setting up of ICT teams, establishing M&E teams, securing the equipment. I remember in Nairobi, we wanted to put this system in one of the facilities, but they don't even have any form of security. And we knew when we take computers this day, tomorrow morning there will be nothing. And then the question of sustainability thereafter. And if we do that, then we'll move away from the paper-based systems towards much more complex forms of health data and make Kenya a healthy, productive, and globally competitive nation. Thank you.
Thank you very much, Dr. Sitinei. See, I told you. See, it is very interesting. Tumuongezee time. Tulisema tukae, to engage, tufanye practical, si ndio? Let us give him another round of applause, a better one. Thank you very much. Now, can I have the presenters, those Dr. Eda in front, Dr. Mutaha Kangu, Dr. Sitinei, let us have a quick plenary session. We are going to, as per the program, we may push one of the presentation behind in the afternoon. So we will close with these 3 presentations, but have a quick plenary. So as I said earlier on, we are going to go for late lunch. We'll be going for lunch at 2:15 p.m. Kindly bear with us. So the panels are here. The panelists are here. Very rich information from them. So the secretariat kindly help me with the rooming in mic so that we have this plenary to be very successful. So kindly raise up your hand. We will be picking maybe the first 4, then the second 4. So kindly, if your colleague has asked a question, a similar question, don't repeat. Let us ask different questions. So, your hands up. So we'll pick like 1, 2, 3, 4, and then 1, 2, 3, 4, so that we give equal chance. Indio? So I can see a hand up there, Waziri Kakamega. Please just allow us to be saying the county as we are engaging so that we'll familiarize with your names. Daktari here. I know you have Dr. from Bungoma. And then here. Yes, Your Excellency, the Deputy Governor. I'm very fair, so we'll be picking. So we don't have question on that side. So I'll give a chance here. Waziri from Kilifi. So mtusamee tukisema tu waziri. Majina tutajua baadaye. So let us have a quick question. So we can start. Okay, just start from here because he has them. I give it to His Excellency the Deputy. He can ask the first question, then you ask, and then you ask, you ask. Then we have another round.
Thank you, Katra. Mine goes to Dr. Ada, who was giving the overview on devolution and how far we've gone. Now, mine is on the CBA and between the KMPDU and the various unions versus the county governments and the national governments. So I just wanted maybe an highlight on how we've handled this since we are being threatened for an industrial action probably in January due to the CBA that was not actually honored, and also we are seeing a lot of threats because of the delayed salaries. So in the overview, how have we handled this and how do we intend to maybe mitigate and offer our service delivery, uninterrupted service delivery? Thank you.
Thank you very much to all the presenters. It was very good presentations. But my question is to Dr. Sitinei on the electronic information system that the government is planning to roll out. What are the timelines? Because some of us need this like today. Thank you.
I want to appreciate the presenters. It was really wonderful to hear Professor Dr. Kangu and the rest. My question goes to Dr. Stienei, and this is about data. You have come up with a very elaborate vision about the comprehensive digital health information system. Yesterday we had another meeting, a pre-conference meeting, and one of the key issues that came out was data. We have many implementing partners who are also collecting data, and we feel that we should be the custodian of data as government. How is this system going to incorporate what the data that the partners are collecting so that we have one reporting center? Thank you.
Thank you very much. As I was introduced, I'm CS from Kakamega. I appreciate the presence, and my questions to Prof on the issue of policies. And I hope the slides are going to be shared after this. Now, the first question, Prof, is what do we do with the verbal policies, roadside declarations? Because you have given us a very good, elaborate system of making policies. So what do we do with the roadside or verbal policies? Number two, if national government makes a policy where counties are not involved, are we authorized to disregard it or not implement it? Number three, if 2 or 3 counties have the same issues, same problems, same demands, are they able to come together and make a policy that governs issues within those 2 or 3 counties? For example, if you have issues of drought in 3 counties in the north, or you have issues touching floods down in the west, these 2 or 3 counties allowed, or is it possible? Just thinking outside the box. Then lastly, you talked about if you are trying to levy taxes or charges, then the legislation is a must. Now, here we have been told clearly that we are supposed to basically enact the FIF bills. Now, in regard to this, I would like to know what is the difference between taxes and then service charge or levies as far as this is concerned. Thank you.
Thank you very much, Waziri. I think we need to take another round. They said those questions are not enough. They need more. So we can have another quick addition 4. Maybe just next to was, sorry, you'll introduce yourself. I don't know whether you are a Waziri or because you are not with us. Then we have you, 1, 2, and then here, Waziri. Because we gave chance to men here, let me give to a lady. I can see there is a hand back. So Waziri Nandi, and then Waziri West Pokot. Elgeyo Marakwet. I said mutatusamehe. So another round. Please ask one question so that you give time also to your colleague to ask question, but don't repeat what your colleague has already said. So quickly, but introduce yourself. I saw you just walk in.
Thank you. My name is Dr. Bahjaj Barak from Lamu County, CEC Help. Sorry, I came at the very tail end of the presentations. And I'm interested in the last one by Dr. Sitienei. I was wondering if as a county we had plans to install some of these softwares. You know, I got some bits and pieces towards the end of the system that we intend to install. We were thinking things like SciHorse or FunSoft. So should we proceed and procure and install those systems, or will they have a problem when this system that you are talking about comes on board? Or will there be like synchronization or something? Then I would just like to ask, is it possible to have a recording of the earlier presentations so that, not just slides, recording? Thank you.
Thank you. Kindly note that all presentation will be shared. The secretariats behind will be picking the correct emails and the full names of the waziris, because we have now to have new emailing that will be based at the COG. Kindly, when the list is going round, just put your right emails, your full names, and your telephone numbers. So yes, Waziri.
Thank you. My name is Cyril Wayongo. I'm the county attorney Bungoma. Mine is more of a comment than a question. And this arises from the presentation by the good Professor Dr. John Mutaha Kangu on the issue of policy and legislation and the role of the county attorneys in supporting the CECs on this aspect. We realize that many of the counties have not been fully utilizing the position of the county attorneys in helping them in coming up with legislations and policies within their counties. I want to say this because of, this is a new phenomenon. The Office of the County Attorney was established in 2020. Among the roles the Office of the County Attorney performs is to be a principal legal advisor to the county government and also responsible for revision of county laws, as well as advising departments on legislation and other legal matters. What has been happening most of the time is you realize at the national level, for example, the Senate or the National Assembly will be generating a law that more or less claws back the gains of devolution, to the extent that they will do newspaper advertisements calling for presentations on comments, but nearly no county does a comment. So the laws goes through the process, is legislated, and it's at that stage that the county government through COG then in reactionary either goes to court or they do protests. So I want to challenge the CCs who are here that fully utilize your county attorneys within your departments, within your county. Whenever there is any law that is coming up or a policy statement either by the national government, sit down with them as technical persons and with the lawyers so that you clearly analyze them and see which areas they're going to affect you, on whether they're in compliance with the Constitution or whether they're drawing back the gains of devolution. So at that stage, we have agreed that we'll be doing memorandums to either the Senate or the National Assembly addressing those issues so that we arrest the legislation at that stage. In fact, when you realize from 2013, when you were doing the leasing for the equipment, it was an illegality because any sharing of resources or where the county government is giving back functions which are meant for them to the national government, there's a process within the Intergovernmental Relations Act on how that should be done. So our challenge is that we need to have also the CECs engaging the county attorneys, your respective counties more, so that we be able to protect devolution as it were. Thank you.
Thank you so much, Attorney. That's a very, very important point to note. Kindly take it up. You all have attorneys at the county level. But I think from now we'll be able to harmonize and see how we can be able to utilize the resources that we have also at the county level. So thank you very much for that. Yes, Waziri?
Good afternoon, everyone. Mine is a comment and also a question. I want to thank Dr. Setiene with his team because I have seen them come a long ways in the digitalization platform in Kenya, because definitely you cannot have any UHC without time-accurate data. On the issues to do with the telemedicine, my request is, it is being piloted in one county. Can we have it rolled out like yesterday? Because we've already been doing telemedicine in oncology and radiology in Nandi County. But if this one is available, I don't think it is one of those that we need to wait. Also on the community health platform, knowing what we have in our households, I think that should not be in piloting, it should be rolled out right away. And for the other counties, being my second term, I would advise you, if you're in any form or stage of procuring any HMIS system, I think I would advise you to wait because you will waste those resources. When Dr. Sitiene talked about the vendor lock, that is real, we went through that. And these vendors, whatever you have in your procurement process, they will not come through with that. So they will come and request for service contracts. Other issues will come up and you will not have access to your data. So I'm thinking using one platform with a unique identifier will also be helpful for the country. Especially for the, and then one question for Dr. Sitiene, the unique identifier. I know when they registered the whole country for the Huduma number, I was hoping that would be the unique identifier. And you mentioned a regulation will be coming in regards to that. Is it going to be the Huduma number or is it something new? But that is key in the success of digitalizing the health platform. My last question on data security. I know technology is very good and has done wonders to many sectors. And Kenya has reached a point where they're appreciating the blockchain technology. It has been a problem in the banking sector or security sector. I think with health data being very sensitive, I don't know if I missed it, but that would be one area where we would really have a lot of issues on data security and hacking of the systems. Thank you.
Thank you so much, Waziri. Data. The last question, maybe from you, Waziri Elgeyo.
Thank you. I have 2 or 3 questions. First to Dr. Sitiene. Or rather about this Waziri who from northern Kenya, said Mandera. Yeah, about F5. You said about 17 counties have passed F5 but have never implemented. We, in my county, also have an F5 that we were never able to implement. We are pushing for an amendment. I just wanted to hear what you have to say about what are these things that made it unimplementable, or counties fail to implement them. What are the challenges? What are the issues, so that we don't face the same? For us, for example, specifically, the revenue team were against it because it was going to cut their performance. Have you seen such an issue elsewhere? How did you go about that? The other thing is, and I feel I speak for many, we need a system like yesterday, Dr. Sitiene, to track on real time supplies for drugs. We don't want to be hearing nowadays complaints coming through directly to the governor, to CEC, about dawa imeisha. Like, it's always an emergency. And I am personally looking for a system and appealing to partners. If you have a system already that is there just to be rolled out, we need that like yesterday. So in the face of what you talked about, do we have a system now for tracking medicines and such things, so that we are, yeah. Basically, let me just stop there, but generally to everyone, sorry, allow me, please, about the 110, like you invest 1 shilling in prevention and you save 10 shillings. If that is true, then why have we seen all partners running away from prevention and working towards secondary care, tertiary care? Why aren't we investing in, and yet you talk about discussing thinning out of resources? Why aren't we back to primary health care? Thank you.
Thank you very much, Waziri. Now you'll be the advocate. As said earlier, we need really to invest in preventive care so that we don't need to focus more on curative care. I know NHIF is in this room, so he will be in the panel session. We will engage him seriously on that. We really don't need to just cure. We want to prevent. So thank you very much. I'll give my panelists 15 minutes to actually answer some of those questions. Kindly be very brief, but make sure you do justice to all the questions that have been asked. So I will start with you, Prof. Meanwhile, as they are responding, we are live on the COG YouTube channel. Kindly log in, Council of Governors, Kenya. We are live on YouTube. We are going to share this link also on your WhatsApp. Kindly just share in, spread it widely, let people know that we are here and we are live streaming on YouTube channel. Thank you.
A number of questions were directed to me. What do we do with the roadside declarations, verbal policies, and so on? Now, my advice is that as a minister in the county government, you should lead the way. And as an advisor to the governor, work very hard to discourage your governor from making roadside declarations. But even if he has made them, and eventually they come to you for implementation, you have a responsibility to scrutinize it, and where there are any problems, advise. Your Excellency, I know you may have made this and that, but I think by an oversight, you didn't see this. You know, you have to know how to play polite. You don't just go and tell him you are wrong. You must find a polite way of saying, I have been looking at it, but I noticed if you had looked at this, perhaps you may have a different view, and I suggest this is the way we should go about it. Or that you have made this, but this one will require us to translate into legislation, into a document, and because it requires us to vote money and things like that. So you need to find a way to advise, your key advisors. If he makes those roadside declarations and you start implementing them without caring whether they are right or wrong, at the end of the day you'll be blamed. And I will tell you, politicians are politicians. Kikiumana, it is you who will be fired. Why didn't you advise me? If you saw it was wrong, why didn't you advise me? So you need to advise. Number two, if the national government makes policies without involving us, do we just ignore the policy or not? Of course, it's not the best thing to do, but the reality is that where we are, some of the policies that are not being implemented, some of the circulars that are not being implemented, sometimes it may be that people are ignoring them because they didn't bother to ask us, isn't it? So this is a message to national government, and this I have said in many meetings, that it will be in the interest of all of us, because the process of policy making, the process of legislation making is a process of learning. It's a process of educating each other about the policy. If we worked on it together, we will not even require dissemination after it has been passed, because by the time it is passed, we all have owned it. We have seen the value of it, and we run with it to make it, and so on. So what I'm saying is that the thing that we are urging is that since county governments have powers to make legislations, go through these policies that national government is making. And if they are good, and perhaps maybe our concern was just the process, we can continue fighting over the process, but we pick out the good things and start implementing them through county legislation for the benefit of the citizens. But that doesn't mean we will stop reminding national government, MOH, that we need to work on these things together. We will not stop making noise. We will continue making noise when we think they are doing wrong. Because you know, habits die hard. And if we allow wrong habits to develop, they will continue. So we have to keep reminding them, the law requires this, let us go it the right way so that we move together. Number three, can 2 or 3 counties make one policy or make policy together? Number one, each county government is a government on its own. Yes, nothing stops you from sitting together and pooling resources and saying, this is a good thing, let's work together, we develop a policy. And nothing stops one county government from having a policy or a legislation that is similar to the policy and legislation in another county, except for the name of the county. So you can work together, develop one policy which you think is good in a particular area, but once you have developed it, you must go and take it through your own processes of legitimization, which means that that policy, that legislation must be adopted by the county government structures of your county. If it needs adoption by your cabinet, it must be adopted by the county executive committee of your county. If it requires to go through the county assembly, you must take it through the county assembly. You cannot say because Mombasa passed it, we can just start using it in Kilifi. It doesn't work like that. The law doesn't allow that. But pooling resources, there's no harm, because we have said learning good practices from each other is a big thing. So if you see one county has done something and it's working, nothing stops you from going and picking their legislation, and you tweak a few things here and there and adopt it in your own place, and you get it working. So that's how I look at it. Now, if you are trying to levy taxes and so on, now if you look at Article 209, it draws a distinction between taxes and charges and levies. And those of you may have had an opportunity to read my book on constitutional law. of devolution in Kenya, I have tried to define the two terms there. What is a tax and what is a charge? A tax can be imposed even if it does not have any accompanying services or benefits to the person paying. But a charge is related to services that are being delivered. And if you look at the 209, you clearly find that they are saying taxes have to be imposed through law, and charges, there may not be specific that, but the point is that our own constitution, and the governor talked this morning about where we started from when we had allowed facilities to retain the money they raised to use to improve the facilities. But then when we adopted the constitution clearly says that all monies due to the county government shall go to the county revenue fund, except if excluded by a legislation, an act of government or of national government or a county government. And if you go to the Public Finance Management Act, section I think 109 and 116, they make it very clear that a county government could, through its own legislation, exempt certain monies from going into the county revenue fund, and then of course allow you therefore to establish a special purpose account into which that money goes. And in my view, quite a number of counties have used that. You could pass an actual legislation, a law, or you could do regulations to the Public Finance Management Act to enable you to exempt these monies from the CRF. And so, and counties like I think Nakuru used regulations. And regulations can fit within the broader definition of legislation, and you exempt that. And that's why we are emphasizing, take the decision, persuade the CECs, the MCAs, get these things in place so that when you start allowing the counties or the hospitals to retain money, nobody will question you. The control of budget will not question you, because you would have managed to have regulations or legislation passed. Thank you.
Thank you very much, Prof. Probably if you have not answered all the questions, lunchtime we can interact. We have good time. Kindly try to engage Dr. Mutaha. I'll give the other panelists 5 minutes each because of time. Kindly see how you can utilize and respond to all those questions within 5 minutes. Wazirieda?
Thank you, Your Excellency, about the question that you asked about KMPDU, how the county and the national government has been handling the union. Now, first and foremost, industrial harmony is one of the most important, fundamental, important issue in the health sector. Because when we do not have industrial harmony, HRH harmony, it becomes very disruptive. The services that are hitherto supposed to be provided by way of rights enshrined in the Constitution becomes neglected, and the respective, county governments and national governments bear the brunt of the responsibility. Now, having said that, then the issues that were attendant to this KMPDU issue is the issue of recruitment, retention, promotions, and the work environment. At least I'm happy that, in the last term of government, industrial disruptions have been very limited. In as far as recruitment is concerned, the position of KMPDU is that, all doctors to be absorbed. This is not very realistic because every government, every county government has a limited amount of resources. And those resources are budgeted within the constraints of what is it that is the top priority at that point in time.
But the counties have recruited very many doctors over time. And one of the issues that we have been trying to push with the national government in the previous term was doctors, when they are released for study leave,